The decision to pursue this study was a reflection of poor outcomes in this space, particularly for patients who have relapsed disease. The CAR T-cell immunotherapy targets CD19. It's dependent on the CD28 co-stimulatory domain. And to facilitate better manufacturing, we undergo a process of T-cell isolation. This takes the blasts out of the manufacturing, and so it enables us to get a better product than on the back end. So the T-cell isolation occurs prior to the viral transduction and expansion. The manufacturing takes around 2 weeks. During that time, this clinical trial provided several options in regards to bridging therapy. Once the CAR T cells were manufactured, patients would receive standard fludarabine and cyclophosphamide conditioning, followed by the CAR T cell infusion. We put a lot of work into the phase 1 part of the study to optimize the cell dose and to optimize the management of toxicity. Very specifically, we now intervene with steroids or tocilizumab or both at lower grades of CRS, meaning at grade 2. And for neurotoxicity, we don't utilize tocilizumab. We restrict our management to corticosteroids. With this background, we enrolled adult patients, again, those 18 and up, with morphologic disease. That means 5% or more lymphoblasts. Patients could come on with CNS disease, but not CNS3. CNS 1 and 2 were permitted. Patients could have received prior CD19-directed therapy, including blinatumomab. Patients were followed for overall response as the primary endpoint. Secondary endpoints included duration of remission, overall survival, relapse-free survival, and then standard correlate studies, expansion, cytokine production, and so on. We enrolled 71 patients and treated 55. The main reason patients did not go from enrollment to infusion was infection. Patients needed to be afebrile and without evidence of bacteremia or fungemia at the time of cellular infusion. There were some patients who also came off due to a lack of eligibility. Again, we required that patients have greater than 5% blasts and that those blasts express CD19 in order to be treated. Among the 55 we treated, the median age was 40. The oldest patient was 84. The patients were heavily pretreated. We saw that about half of the patients had had prior blinatumomab, almost half had had prior allogeneic stem cell transplant, and about a quarter had prior inotuzumab. The median blast burden was also high at the time of enrollment. It was around 65%. With the bridging options, we did not see a meaningful decrease in the blast burden. It had dropped to around 59%, but essentially stable from enrollment to infusion. Following infusion of CAR T-cell immunotherapy, patients were assessed at day 28. We saw a CR/CRI rate of 70.9%. The true CR rate was around 56%. The CRs were largely MRD negative. Specifically, 97% were MRD negative. Sorry, there was one patient who was non-evaluable, hence we can't say 100%. In total, 10 patients went on to receive allogeneic stem cell transplant. 9 of these patients were in a CR or CRI, and one of these patients had an aplastic bone marrow at day 28. When we censored for duration of remission for those patients who had an allogeneic transplant, we could not show any difference in the duration of remission. Specifically, the median duration of remission across the study was 12.8 months. Specifically for patients who were in a CR, the median duration of remission was 14.6 months with censoring and was not reached when we without censoring for the transplant. When we look at the 1 year duration of remission, we can show that approximately 1/3 of the subjects are in ongoing continuous remission without transplant. Looking specifically at our other secondary endpoints, median overall survival was 18.2 months. The median overall survival was not reached yet in those patients who achieved a CR or CRI. The median relapse-free survival was 11.6 months, and in those who achieved a CR or CRI was 14.2 months. When we track response rates across various subgroups, we could not show any impact from prior blinatumomab, from prior transplant, from prior inotuzumab, or among those with primary refractory disease. We could not show any impact of age, and in fact, those 65 and above had a 100% overall response rate. The only factor that impacted response was those who had a blast count of 75% or higher. In that group, the CR/CRI rate was 42%. With regards to safety, there were no new signals when we looked overall at our adverse events. The most common grade 3 and above adverse events were anemia and fever. With regards to CRS and neurotoxicity, grade 3 and above CRS occurred in about 1/4 of the patients, and grade 3 and above neurotoxicity also occurred in about 1/4 of the patients. One patient did pass away from grade 5 cerebral edema. Looking at expansion kinetics, those patients who achieved a CR or CRI had better expansion than those who did not. Those patients were also more likely to be MRD negative. We also saw higher expansion in those with grade 2 and above CRS and grade 3 and above neurologic events. The median time to peak CAR-T expansion was around 2 weeks. Looking at patients over time, among 10 evaluable patients at 1 year, 1 still had persistent detection of CAR-T cells. The other 9 did not. I think we're very excited by the results of the study. It shows a very high response rate, particularly given how refractory and how many relapses these patients had. We're also, quite pleased by the safety signature. We did have one unexpected death due to cerebral edema. There was another death related to infection post-CAR-T, but looking across, the study overall, particularly when we think about how advanced this patient population is, I think we've demonstrated that CAR-T cell therapy can be safely delivered to adult patients, and so that's also something that's very exciting. I think when you look at the ultimate benchmark for where you land in terms of that safety and that efficacy component, it's overall survival. And to look at this data and see a median overall survival of 18 months and one that's not been reached yet in our responding patients, it's really quite profound. The study is currently with the FDA and I suspect the EMA at this point in time, and so hopefully we'll have something that we can now bring to patients with relapsed and refractory disease in the coming months. Certainly, I think it will significantly improve our survival expectations for patients in this situation.